We ready?
Hello, I'm Dr.
Okay.
Donecker that's going to present about Synovitin OA. And I'm going to,
So Jay,
yes,
let me just do a little bit of housekeeping.
okay.
So hold on one second. Welcome everyone. I'm glad you're able to join us for lunch and spending it with us. Just a couple house cleaning items. The Q&A function is for any questions that you may have. And then what will happen is we will actually address them at the end of both of the talks. The chat function will be for if you're having any technical issues. Okay, so I'm Dr. Cindy Knapp, and I just wanted to say thank you to Exuberant for not only sponsoring this event but also co-presenting. And I'd like to introduce Dr. Jay Donecker. Jay serves as the Chief Veterinary Officer at Exuberant. He brings with him 40 years in veterinary medicine, including serving as a practicing veterinarian and partner in a mixed veterinary practice for 20 years, then as a veterinary consultant, technical service and outcomes research veterinarian for Pfizer Animal Health / Zoetis. For the last 6 years, Jay has overseen the development of Synovitin OA from a concept with lab animal validation of safety and effectiveness to a commercially now available veterinary device to treat. They started treating elbow OA that's been refractive to routine veterinary prescribed treatments. Today, he will provide the clinical research results of year-long studies that were conducted in client-owned dogs. So I'd like to introduce Jay Donecker.
Thanks, Cindy. I really appreciate that. I'm going to switch to my presentation screen. Okay. And it's been a very interesting path over these last 6 years. You're speaking to somebody who was in practice, who all of a sudden had to learn all the new physics measurements as we were developing this radioisotope. This whole idea started a number of years ago because eventually it's going to be used in humans. Along the way, they needed to do translational studies, and that's where I became involved, since I was involved with that in outcomes research for Pfizer and Zoetis. So it's been a very interesting trip, and I want to share with you where we are now. At this very moment, since this has been commercially available, approximately 300 elbows have been treated in about approximately 200 dogs. So we're starting to get some real traction with people who are wrestling with these young dogs that have elbow dysplasia diagnosed at a very young age, and they become refractive to current conventional strategies pretty young in their life, and they're very active. And it's kind of nice to have a treatment now that is helping to address this need. I'm going to play a video, and I just want to, hopefully, you all can hear it. Okay, sorry about that. There's technical difficulties that you can't hear that video. What that video was going to present is why Exuberant ever decided to address the gap that is present in treating elbow OA. As we know, the OA is very common. It's the most common source of chronic pain. Chronic pain is the term we like to use. A better term would be maladaptive pain, because when a joint becomes inflamed and you have synovial hyperplasia and hypertrophy, you also have an ingrowth of unmyelinated C fibers, which neurofibers, which exacerbate the pain that the dog is feeling from the inflammation associated with the chronic inflammation that's occurring. If it's left untreated, we all know that a very lame dog, it does not have a very good quality of life. Osteoarthritis is not a disease of the cartilage alone. I know we all focus on it. We all focus on whether there's a cartilage degeneration, eburnation of the bones present when we take radiographs and looking for osseous proliferations. But it's really a total joint disease. There is substantial inflammation that is occurring throughout the structures that surround the joint, particularly the synovium. And clinically, it's very hard to assess the synovium. Not many of us have an MRI available, and even when you do, within the dog, it's very difficult to really do a good assessment of synovitis. Now, you can do a histologic biopsy, of course, through like an arthroscope, but very few will do that, and it's really not indicated practically. When you have an inflamed joint, you have a lot of cascades of cytokines going on, and we've had, there are books written on these different cascades. One of the most important points that I'd like to make is the macrophage in a chronically inflamed joint plays a very large role. That's why when you take a joint sample, many times your joint sample is read out as being chronically inflamed because of the amount of monocytes and macrophages that are present in that joint fluid sample. There's been a very good paper written about the role that the macrophage plays in the propagation of inflammation associated with osteoarthritis by Dr. Bondison. This has been out about 15 years, but it really pulls together the essence of why the macrophage needs to be focused on. And it's because it modifies all these different cytokinetic cascades that are occurring due to the inflammation. And unfortunately, the macrophage plays a very large role in propagating the continuation of this inflammation. So what you see on an arthroscope is shown here in the very center. You see a hyperplastic synovium. It's also hypertrophy. You see a lot more reddening and swelling that's associated with inflammation. What we're speaking about here is treating joints like this with a radioisotope. Now, radioisotope has different types of radiation that can be used for therapy, and some isn't used at all. There's the beta emitters, which are yttrium and rhenium, which very often have been used in the past to treat joints in people. And that treatment has actually gone all the way back to the 1920s when Madame Curie actually looked at it. But commercially, it's been used in Germany and Europe primarily since the 1970s, primarily yttrium and rhenium, both of which are very high energy electrons, beta emitters. What we have developed with Tin 117M, and that was in the video, one of the people that was a prime researcher that developed it was our chief operating officer, Dr. Nigel Stevenson, in which Tin 117M is unique, in which the emission that is therapeutic is a conversion electron. And conversion electrons basically are jumping from one orbit to another of a metastable radioisotope. In the jumping, it's only a certain distance. So for Tin 117M, the length of the emission is only 1/3 of a millimeter. So that leads us to be able to be more specific in where the radioisotope can be placed and not have to be concerned about adnexal structures being unnecessarily radiated by therapeutic radiation that's actually too high of an energy for those cells. There's gamma radiation that does occur in this radioisotope. Gamma radiation is not therapeutic, but it is gamma radiation in which the go-home instructions with a treated patient, the caretakers need to follow. So I'm mentioning about treating joints with a radioisotope. It's called radiosynoviorethesis, which is the interarticular injection of a radioisotope. In our case, it's Tin 117M metastable. The mode of action is that the radionuclide is absorbed by the synoviocytes or phagocytized by the macrophages. When the macrophage engulfs the radioisotope, that macrophage will be slowly killed. And that's very important because if you have a very quick kill of that macrophage, it will cause necrosis of the macrophage, a breaking apart of that cell, and those cell fragments will create an inflammatory reaction. This radioisotope, because it's extremely low energy with a long duration half-life, slowly kills the macrophage, causing it to die by a process called apoptosis, which I'll describe in a little bit more detail in a moment. But TIN-117M metastable has extremely low energy, 156 kiloelectron volts, which we don't have any context of. A slide that'll provide that in a bit. Where synovitin is working is the vicious cycle of inflammation that's occurring within a joint, primarily involving the synovium. As the synovium becomes inflamed, it starts those cytokinetic cascades that I illustrated a couple of slides before, but it's also stimulating the production of macrophages, and the macrophages are pro-inflammatory cells, which then also you get into this vicious cycle of the macrophages causing more inflammation is causing more cytokines being released, stimulating more macrophages. At the same time, whatever the inciting cause was for the inflammation of the synovium, such as instability in a joint with, let's say, elbow dysplasia, that also is continuing. So this treatment will be to address the inflammation of the synovium, realizing that the underlying problem, let's say it's instability of the joint, this treatment's not going to cure that. What this treatment is doing is taking and reducing the inflammation of the synovium. And I'll pass right past that video since you wouldn't hear it anyway. The effect of TIN-117M I have here in the schematic. And basically, because of the inflammation, the pro-inflammatory macrophages are recruited. Their job is to engulf cells within the joint fluid, which are present due to inflammation. Unfortunately, when they engulf those cytokines and other cells, it causes those macrophages eventually to go to the synovial crypts, where they, again, will stimulate more inflammation. However, if they have engulfed the radioisotope TIN-117M metastable, it will slowly kill that macrophage. Now, while it's being killed, that macrophage is still migrating to the synovial crypts where there is inflammation occurring. The goal, and it occurs over an extended period of time, the hyperplasia is reduced because this therapeutic radiation is nonspecific. So the inner layer of the synovium that's also getting exposed to the conversion electrons that are within 1/3 of a millimeter of that macrophage that's in the synovial crypt, those cells are also being affected as well, and they too die due to apoptosis. So I've mentioned apoptosis and necrosis. There's some similarities, cells die, but the difference is that with necrosis, you have quite an inflammatory process occurring. With apoptosis, you have almost none. So there's no real inflammatory response due to apoptosis because the cell, when it dies by apoptosis, it's broken up into small fragments in which the plasma membrane is still surrounding. So even though it's broken up, even though the cell has died due to apoptosis, there is not an inflammatory response. And so the purpose of TIN-117M metastable, which is retained within a colloid, is to be put into the joint in which the colloid keeps the radioisotope within the joint, doesn't migrate through because these are microparticles. But at the same time, those microparticles in the colloid have to be small enough, between 2 and 20 microns, that the macrophages will phagocytize those micelles. When they phagocytize the radioisotope colloid combination, that is what eventually will kill the macrophages. Again, over an extended period of time. The half-life is approximately 2 weeks. Rule of thumb with these radioisotopes is their therapeutic radiation is delivered over 5 half-lives. So basically, during a period of 10 weeks for TIN-117M metastable, there is irradiation going within the joint, which is therapeutic. I mentioned earlier about how TIN-117 metastable is so much lower in energy. So for a comparison, I've shown similar energies, maximal energies of yttrium, rhenium, erbium, and TIN-117M metastable. These yttrium and rhenium are used for larger joints. And they can get away with that in human medicine because the joints are larger and the distance that the emissions occur of the beta emissions is such that it affects enough of the synovium that it does reduce the inflammation. However, when you get into smaller joints, there's too much energy to put in a small joint. So those radioisotopes are inappropriate for small joints in people. That's what stimulated the development of tin 117M. What was requested to be developed is a radioisotope that can be put into small joints. Once all the safety studies were done with the laboratory rats, they then had to move to a translational species. That's the dog. That's how I became involved with this process. We needed to set up a model in the dog to show that this low energy radioisotope tin 117M metastable could safely be used to treat inflammation, synovial inflammation, within a small joint. And that's how we were able to bring this along to a point where we now are able to treat dogs commercially, while the other process of getting it developed for use in people continues in a parallel track. I also want to point out to you that the maximum tissue penetration for tin 117M is, again, 1/3 of a millimeter, as compared to erbium, which is over just a little bit over a millimeter. But you look at yttrium and rhenium, it's a much greater distance. So more adnexal structures are affected in the smaller joints. Many of us in veterinary medicine have some experience using before tin 117M, iodine 131 to treat cats with hyperthyroidism. There's a huge difference between these two. With iodine 131, that is a systemic therapy. It is excreted by the cats. You have to keep them in radiation quarantine because they can excrete it in the urine as well as in the feces. And you have to be very careful about where that cat is kept for the initial weeks post-treatment. Tin 117M colloid was developed so that it was kept within the joint for an extended period of time. And we have studies now that show that the colloid is still present 90 days after injection into the joint. It is not excreted. It does not need to be kept in radiation quarantine prior to going home. There is a gamma emission that the homeowners have to be protected against, in which they interact with their dog for normally 2 to 3 weeks, depending on the dose and the number of elbows that have been treated. I mentioned a number of preliminary studies that we did before a dog was ever treated. These are the laboratory rat studies that were done over a course of a number of years. Many of these studies are required before it can be used in humans. And so we went forward and used these same studies to justify us being able to use it in dogs. So greater than 350 rats have been studied with this product, colloid. The study in laboratory rats was done in their knees, not in their elbows. So the bottom line is the synovial joint reacts to this product, whether it's an elbow or a knee or hip or whatever. But all our data in dogs has been gathered in elbows. What's interesting is Dr. Allison Bendeley, who is the pathologist at Boulder Biopath, she saw in one of the studies, she felt that there was enough remodeling in the laboratory rats that she felt that it could be considered a disease-modifying device in the rat. We do not have any studies in dogs that we've conducted that would match what we know has occurred in laboratory rats. So we then did, of course, a safety study first in colony-bred dogs to find out, is it still safe? The dose used was 40% higher than what we are using in our label dose. Even at that higher dose, and this study was done by Dr. Latimer, published in Veterinary Radiology in August of 2019. He found no significant adverse effects in normal elbows that were injected with this product. These dogs were treated and then they were euthanized and then histologically had their elbows examined at 45 to 47 days, depending on the day that they were euthanized. We then followed up with 3 studies in companion dogs with Klein-owned dogs. So the safety study, there's a lot of serial values that were obtained during that 45 to 47 day period for these 5 dogs. Most importantly, it verified that greater than 99% of the tin 117M activity was still retained within the joint at 45 to 47 days, which basically supported that the colloid was staying within the joint, which is very, very important. I did want to call out that the dose that was examined was 40% greater than what our label dose is. And this again has been published in veterinary radiology. There was no fecal or urinary excretion that occurred when the colloid stayed within the joint. So we have to ask, between the early safety study done in 5 colony bred dogs and then client-owned dogs, how safe is the product? So when we finished our study, 74 dogs, 96 elbows had been injected with a lot of serial data collected on all these items that I have listed here, starting at physical exam, going to brief pain inventory, Colorado chronic pain scoring, radiation emissions, scintigraphy. These studies were conducted at 3 sites, University of Missouri, College of Veterinary Medicine, Louisiana State University School of Veterinary Medicine, and then Gulf Coast Veterinary Specialists in Houston. And again, there were no safety associated parameters which fell outside of the expected norms. And we also had a misadministration. I'll digress here. That misadministration was not discovered till the following day when that joint underwent scintigraphy. The issue was it did miss the joint, therefore it was not going to have an effect on the joint. There was no excretion, urinary excretion or fecal excretion with the missed joint. There was no tissue damage caused by the missed injection. And we knew that this should happen because we had already conducted a study in laboratory rats where we actually did inject them underneath the skin. Also gave it topically to recreate, let's say, a dog licking at a site that had just recently been injected. And also gave it IV in case somebody inadvertently injected this colloid IV when they were trying to inject a joint of a dog. And all those studies showed again that because of the low energy, there was not an issue or an adverse experience created by this misadministration. But the worst part of the misadministration is what I just said earlier. It would have no effect on the joint. And with a commercially administered product now, if you inject a dog and miss the joint, that dog still can't be treated again for another year. So it behooves us to always make sure that the injection is going into the joint so the full effect of the radioisotope can occur. And this would probably mean that if you're not sure if you're in the joint, use an ultrasound probe to show that you're in the joint or even digital radiography. But it's mandatory that the knee be in the joint so that it will work and be effective. Safety-wise, the dog won't be injured. I've mentioned in these studies going forward, I'll mention about the grade 1, 2, and 3 elbow dysplasia. This is the gradation that the International Elbow Working Group has developed. There's also a grade 4 that I don't list. That's the elbow that's trying to ankylose, and really it's a no-hoper. But all our studies were in grade 1 and 2, grade 3, and then repeat re-injection of grade 1 and 2 elbows that had been treated previously. So in the first study, we were trying to accomplish a number of things. We wanted to accomplish what the proper dose was and the safety and the effectiveness. So we tracked all the safety items just like I've already provided for you. Then we tracked the effectiveness. This study was a little bit different than the following 2 studies because we only injected 1 elbow of 2. And as you know, elbow dysplasia many times occurs bilaterally. So even knowing that, in which only 1 elbow, because we wanted to have the untreated elbow to act as the control for some of our values that were collected. And we also compared the dog to its baseline results. So the overall treatment results over a 12-month period for all 3 doses was 88%. But at the label dose, there were 13 dogs in that group and 12 to 13 had a treatment success. And the treatment success was a composite of the clinician's lameness exam, what the veterinarian saw, the canine brief pain inventory, what the client saw, and force plate, what the machine saw. And the force plate results have already been published earlier this year by Dr. Karen Ver-Aulich, in which the force plate results, which were obtained at Gulf Coast Veterinary Specialists and Louisiana State University, showed that 17 and 19, but 3 doses now, were 89 were successful based on force plate. Of the label dose, there were only 5, and 4 of those 5 were successful using the force plate evaluation. On this slide, I just want to let you see that the red line that's dropping down is the presence of the radioisotope and the radiation, therapeutic radiation that's occurring. And basically, it's present and creating therapeutic radiation over a period of 90 days. Remembering that the first 5 half-lives, 10 weeks, is when the majority of the therapy is occurring. The stars above indicate that there was a successful improvement in the visualization of pain that the owner saw of the dog, and in the visualization or an increased activity of the dog. So the lower the numbers, the better off the dog is. The higher the number, the less active it is and the more painful it is. And you can see over 12 months that there was a successful improvement in both of those parameters, except at 3 months. At 3 months, the level of activity was judged by the owners to be similar to the level of activity at baseline, which just points out, one, only one of 2 joints were injected for the study, but also there's a waxing and waning that occurs with chronic pain or maladaptive pain associated with elbow OA. So this is just reiterating the results that I've just told you. The next study was a grade 3, because you know as well as I that when you first start a new procedure, you tend to take worst affected dogs first, because in case there's any problems, you can say, well, it was a last ditch effort. So we wanted to do it in the grade 3 dogs, knowing that we would not have as high a success as with the 1 and 2, which are arthritides that hasn't progressed this far. And here again, we're not surprised, it was only a 71% success. All these dogs were treated bilaterally if both elbows clinically needed to be treated. There were some dogs that only one elbow needed to be because the other elbow was perfectly normal on clinical exam, lameness exam, and radiographic exam. There were 14 dogs total that had the proper label dose, and 10 of those were successful. This study has just been published in the Public Library of Science. This August, it's open source, and you're more than welcome to go and review that. Here again, this is a nice illustration with this bar graph. You see the gray line, that's the radioisotope decaying over a period of 3 months, 90 days. And you can see that what the client saw was an improved dog at all times, both in their exhibition of pain as well as their level of activity. And those evaluations or surveys were filled out at 3, 6, and 9, and 12 months. Then, of course, we had to ask the question, okay, we've injected the elbow one time, can you do it again? The answer is unequivocally yes. So we took 9 dogs that had been treated in the grade 1, grade 2 study and already been followed for a year, and asked if they wanted to come back and do another 12-month study. And we had 9 owners say, sure. So that's what's happened. That's what's being reported here. This has not been published yet. I'm in the process of writing it up. But the bottom line is, as you would expect, these are dogs in which the osteoarthritis was continuing to progress. And we did not have as good a success. 6 out of 9 were a treatment success, and that was based on CVPI, the clinician's assessment, as well as force plate evaluation. And here again, I'm just showing that the clients at 3 months did not see very much improvement in regards to the level of activity to where we would call it success. But by 6, 9, and 12, they did. They did see improvement in pain by 3 months. So to wrap this up, Synovitin OA is a therapeutic veterinary device. It can provide up to 1 year of effectiveness with only 1 dose. We saw in the mild to moderate OAs, 92%, 12 to 13 success. There was no clinically significant systemic or adverse local side effects. The dose is custom made per dog. It arrives the day after the procedure. There's no inventory. It's an intra-articular injection, takes minimal surgery time. You can release the dog the same day as long as it's below 0.45 millirentgen per hour, which can be measured at 1 meter by a Geiger counter. And and that joint can, or the dog can be treated 12 months later if needed. And the go home instructions have to be provided, and they're very simple to follow. So this product can be used concomitantly with a number of other treatments. It should be considered to be used in place of PRP or stem cells. And dogs that have been previously arthroscoped and repaired, you know those dogs are going to be arthritic in the years to come. And those are dogs that many times will be affected by chronic OA and will need something like Synovitin OA. I'd like to pass on to you about Mykonos, and I will stop sharing my screen if we'll see if actually I won't, because I don't think you're going to be able to hear it, unfortunately. Mykonos was a dog that came to University of Missouri because the veterinarians that had treated it said that basically at a year and a half it was going to continue to have continuing pain, and they really didn't have anything to treat beyond that. And basically we treated as part of the first 12-month study. It came back because the other elbow was bothering it. Over a year later, we treated that elbow again, and then we treated it as part of the re-injection study years after that. Bottom line is that dog was treated twice in both elbows. Last treatment was in December 2017, and it's still running around to this day, very comfortable. And I had a nice video, but the audio isn't coming through, so I didn't want to subject you to watching people's mouths move and not hearing anything. Okay, this is the package insert, which we're more than happy to provide for you. And I will stop sharing my screen. Okay.
So Jay, there was a question. Do you mind answering it?
You bet.
Hold on one second. Okay, hold on. From Wade Wood, are we aware of any contraindications for dogs with permanent post-surgical implants, i.e. TPLOs?
No, we do not know of any. In fact, I do know a dog that was treated that way very successfully. If there's a synovitis associated with the post-TPLO surgery 1 or 2 years later, which you know arthritis is going to occur in that joint, we have no studies that we've conducted in dogs post-TPLO. All our studies are in elbows, but I do know that there is a clinician that has already treated a dog post-TPL. I think it was done maybe 3 or 4 years beforehand, and they've had very good results, which you would expect. Synovitis is synovitis.
Okay. There's a couple more questions. Are you okay with answering them?
Oh, you bet. And I'm really sorry that the video audio didn't come through.
Yeah. So from Rachel Bergman, why do we need to wait 12 months before retreating? What are the adjustments owners need to make post-treatment, which I can go over? And then what is the average owner's cost, which I can go over?
Okay. First question about why do you have to wait 12 months? Basically, the Nuclear Regulatory Commission also evaluated this treatment, and it's been their determination for all states that they oversee the regulations directly, and also most agreement states. They have stated that, in their opinion, to keep the radiation level below 100 millirem per year for people in a household with a dog that's been treated, that dog should only be treated once per year and only one dog per household. Now, I mentioned the amount 100 milligrams per year. I want to put that in perspective. You and I that wear X-ray badges, we can get exposed safely over a year, 5,000 milligrams per year. The general population that the NRC has stated is 100. In the general population, that includes small children and pregnant women. So we have to stay below that. And all our modeling and all our measurements, in fact, we have a paper coming out about emissions in dogs that were treated at Johns Hopkins, in which the other members of the household wore dosimetries and tracked them by Bluetooth coming out shortly. It's well below that. It's about 40 to 50 milligrams. But the NRC at this point says only once per year. So it's a regulatory issue, to be perfectly honest.
Jay, at the other clinics in the East Coast, have they been able to, has insurance covered them?
Yes, I know of 6 insurance. There's basically 10 insurance groups in North America that insure dogs. There are little companies that all are part of one larger group. 6 of those 10 equivocally said, once we were listed in the Compendium of Veterinary Products, big blue book that we used to get, but it's now electronic. It's managed by Elanco at this point. Once we were put in there with our safety data sheet, they will unequivocally cover it. I can tell you that Trupanion for veterans will pay 100% of this treatment for veterans that have service dogs. The other 4 insurance groups, it's a case-by-case basis in which their case managers determine what percentage they will cover for a dog like this. One of the points that people have had a problem with is a dog that has a history from the veterinary clinic that says arthritic, and it happened a year ago. And if it hasn't been well diagnosed, they'll say, oh, it's a pre-existing condition, we're not going to pay. So it behooves us all as veterinarians to diagnose exactly what joint we're dealing with. And exactly if it's chronic OA, that's different than a dog that's sore from overuse of a joint.
Another one, Emily Jewell, I know you kind of answered it. Are there plans to try this product in other locations? I know for knees and post TPLOs, but she also added spinal.
Good question. In fact, I had a meeting with some people associated with service dogs at Penn just a few weeks ago, and they've asked a similar question. We will be conducting a hip arthritis study at Penn. We're about ready to initiate that. Probably in about another month, we'll start enrolling dogs with Jason Circle, Dr. Jason Circle, and the Penn VCIC. That's the only study that I know that we're going to be going forward with at this moment. At this point, what we really need are good, solid veterinary practices like yours, Cindy, that tracks results. And if you decide to treat a post-TPLO dog or a hip OA dog or a tarsus that's inflamed, keep track of it, because that data is something that we can share. Because as practitioners, if we're presented with a dog that needs therapy and we feel there's a therapy out there, whether it's human or whether it's approved for another joint, within our scope of our license, we can do that. But we need good follow-up so that we know what our expected results when these other joints are treated.
And then there was another question on, can they have access to these articles that you have?
Oh, you bet.
Studies?
Yeah, they're all open source. I know Public Library of Science is open source. I know that Dr. Allux is a veterinary medicine research and reports. I'm not sure about veterinary radiation, but I can provide all 3 of them. If somebody sends me an email, I'll be more than happy to share the PDFs. Please be aware that the Dr. Latimer one, the safety, the dose that is being reported there is 40% what are greater than what our current label dose is.
Okay. And then before we move on, Jackie Stone, who is our regional business development manager from Exuberin, just wanted to answer the question about any potential contraindications.
Oh, hey, yeah, this is Jackie. I can't share my video, Dr. Knapp, but happy to answer that question as well as Dr. Donaker. The only contraindication really is stem cells, and Dr. Donaker can elaborate on that because the radioactivity will kill those live cells. and possibly PRP. But when there's an implant involved, there is no contraindication with that, except for you cannot do this injection for at least 1 month prior to any surgery on that joint, because we want that radionuclide to be contained within the joint. And Dr. Donecker, if you want to elaborate, please do.
You bet. Basically, it's exactly like Jackie said. When you have stem cells and you put it into a place, whether it's into a tendon or into a joint or wherever, you're hoping that those cells will multiply. Well, in the face of radioisotopes, that's not going to happen. That radiation is going to kill those cells. When cells try to divide, they're very vulnerable to radiation. So a contraindication would be, if you want to use stem cell therapy, you should either do it at least 2 months prior to following up with Synovitin OA, or the reverse. Let Synovitin get completely decayed, which you've heard me say 5 half-lives is 10 weeks. Well, you also heard me say that at 90 days, you still have some radiation present. So post Synovitin OA, I would never consider doing stem cell for at least 4 months, maybe even going on 6. PRP, I don't know whether we can use that concurrently or not, because PRP, we're not sure whether we want those cells to divide and multiply to have an effect or not. So my rule of thumb is I wouldn't do PRP within 2 months before or after, just because you need to know which treatment's actually effective for that dog. And you start throwing too many things intra-articularly, you could have an untoward effect just because you're putting 2 things in a joint that you really shouldn't be doing together. We have no studies showing those 2 together.
And that's the same for, we discussed about steroid joints, injecting with steroids too?
Good question. I would recommend at least a month either side of a Synovitin injection with a corticosteroid or sodium hyaluronate.
So, were there any other questions? Busy for Jay. Okay, so thank you, Jay. We're going to kind of talk a little bit about how sound, because as you all know, sound is actually now providing this treatment. So a couple things on how, if you have an animal or a client who is interested in it. Basically, what we, as Dr. Donecker was mentioning, it's not a treatment that we just want to throw out there. It's for animals that we're finding, you know, maybe the whole regimen of being on NSAIDs and maybe some pain meds, rehab, and the animal is still not showing any major improvement, and they're just having a really hard time struggling and getting around. So when an animal comes into us, you know, this is what we're kind of looking at is, are they on these currently and not necessarily showing improvement. Whether or not, you know, we go to the point of, you know, first trying out the other joint injections of PRP and steroid or shockwave is really going to be dependent on the actual animal and how, I would say, potentially how severe, like, for instance, like a grade 4 OA, you know, we may not necessarily go to Synovitin. We may go more towards a steroid. So it just is going to be really dependent on the actual animal themselves after we do our exam. Ideally, you know, definitely dogs that have mild to moderate OA would be, you know, the candidates that we would be offering this treatment to. And right now we have done multiple animals and we have mostly done the elbows, but our actual license here at Sound is for any joint. So it's basically for canine osteoarthritis. So if we feel, for instance, like the stifles are the problem, then we do have the ability to do synovitin into the stifles or even the hips. And again, it's ideally for dogs that have tried other modalities that haven't been successful, or it's just not enough to manage their OA. For the referral process, you would definitely refer to Sound Veterinary Rehab Center, with the hopes that you guys have already done the workup, meaning you have done the x-rays for us and are sending us an animal that you know would definitely benefit from this, versus sending us an animal and expecting us to do the full workup. Because we're hoping by then these animals, we know exactly which joints are the problem, as well as, you know, they're on some medications that are actually helping them in a sense. Every owner does go through a pre-screening questionnaire for us to kind of determine if they are a candidate for synovitin. You know, things that we want to get a feel for is exactly their interaction for the animals. Because as Dr. Doniger mentioned, you know, once we do inject the animals' elbows, when they are at home, there are definitely precautions that the owners have to take in regards to protecting them from the gamma radiation. So what we're trying to get a feel for is, you know, are these what we would say typical owners that, you know, they snuggle with their dogs, they feed and play, or are they the ones that are a little bit more in the sense of co-sleeping and the dog is constantly carried, or they can't be without them close to them? Because one of the big things in the pre-screening is, on average, for the first 2 weeks, we are definitely going to limit or highly recommend their interaction with the dog. Not necessarily complete stopping, but this interaction of sleeping with them. We're going to request that they don't sleep with them for the first, you know, 2 to 3 weeks. And it's mostly for their protection of the radiation where the synovitin has been injected, for instance, like the elbows to their chest, okay? And keep in mind that the normal amount, as Dr. Goniger was saying, it is animal dependent. So we're basing the amount of synovitin based on the dog's weight. So, you know, with the normal go homes, it's about 2 weeks that we're requesting them to take these precautions. But about the average amount is probably, and Jay, you may want to, you know, give your suggestions or is about, I usually tell owners, if we took about 4 chest x-rays, is about how much radiation an average dog will get if we actually inject 1 to 2 of those elbows, okay? The problem is it's very isolated to that particular joint, and it doesn't leave the joint. That's the thing. We have to rely on just the natural decaying of that isotope versus the body actually getting rid of it. Is that correct, Jay?
Yes. Can you hear me?
Yes.
Okay. Yeah. Yeah. I mean, that's an excellent analogy for radiographs. This is a very low, I just can't emphasize enough how low energy this isotope is, and the amount of gamma radiation It's a very small amount, but unlike people treated with a radioisotope, household members can get exposed to 500 milligrams per year because of the benefit it brings to the household. The NRC says that that benefit should not be characterized for animals, so we're at 100. It is a very, very low threshold, 2% of what we can be exposed to, and it's a lot of abundance of caution there, a lot.
During the other thing about the pre-screening is we do want to know if, who is in the household, for instance. It may not necessarily be the best treatment if the owners have a lot of small kids who love to be around their animal, as well as if anyone in the household is pregnant. That's another one that we really we may not necessarily, at that time. What is nice is there is no limitation with other animals interacting with the animal that has been treated. These precautions are really more for the people in the household, and that live in the household. The other thing I do stress to the owners is if for some reason, this procedure is very safe. The TIN 117 is a very safe procedure. If there was anything, it is mostly if they had a reaction to, say, the sedation or something that they may have a complication with. But I do stress to owners that if for some reason something does happen with their animal, for instance, they get sick or they need to be brought to the hospital, they do need to notify us as well as the clinic to let them know that their animal has been treated. As well as, if for some unforeseen reason the animal does unfortunately pass away, we within that 120 days, we do need to check that animal for radiation and potentially have to hold their remains until the radiation has decayed long enough. The other thing, right now we are doing these injections monthly. One of the biggest reasons is we do, again, it is based on weight of the animal, how much they will get, and we do have a time period of when we can put in our order, and it's about a 2-week process in order to get the order. And again, until we can actually get them in, we do strongly advise that, we're hoping that we're relying on you guys to be able to manage the case. We're always here to help you, but it may not necessarily be that we can get them in to have the Synovitin injection right away. Usually a Synovitin procedure day, what that entails is the animal is dropped off in the morning. We do pre-anesthetic blood work, and then before the sedation. The procedure itself, the joint injection, is actually fairly fast, depending on how many joints. We are only limited to 2 joints per year. So, during our actual screening, it's really dependent on what we find. One of the questions was about the elbows. Would you treat both elbows if, since you can only treat it once a year? I highly recommend to owners that if they have bilateral elbow dysplasia, but only one is really bothering them, I do recommend treatment of both elbows, because we may treat the one that's really bothering them, and then they're feeling good and realizing that, that other side is now starting to bother them. And unfortunately, we wouldn't be able to inject that elbow again until the following year. So, if there is bilateral elbow dysplasia, we would recommend that. So once the procedure is done, the owners do get a call, and even before the animal is waking up, to head on over, because ideally we would like to have the animal go home once they wake up. Prior to them actually leaving the clinic, we do actually test them with a Geiger counter in order to determine if there is a high radiation residue, which all the animals that we have done so far have actually been at 1 meter apart from the affected elbow. They have actually been at the environmental background, which is really great. And then when the owners come in, we go over all the discharge instructions. We reiterate all the precautions that they need to take, which was discussed at pre-screening and then on the day of procedure. So that's how it all goes. I do have a video of an animal that Jackie Stone sent me. It's not of an animal that we actually injected, since we just started, but I believe one from a clinic, maybe more in the East Coast. Her name's Ella Rose, and she's 11 years old, and she had bilateral OA. So at the beginning of the video, what you'll see is her initial, what she looked at before the synovitin, and then the latter part of the video is 10 days later. So hold on one sec. Here we go. So keep in mind, I mean, I'm really excited. I think this is going to be an exciting new modality to add. Keep in mind, and I stress to all the owners, especially when it comes to elbows, we may not get rid of the limp completely. You know, elbows, you never probably will, because there's 3 bones that are just not fitting correctly. But if you can see that change in that they're a lot more comfortable, they're willing to do a lot more, I really think we're, you know, it's working. As well as I really stress to the owners that, you know, you may not see that significant improvement until a few weeks later. You know, every animal is different. I love the fact that, you know, Ella Rose was at, you know, 10 days, but it may not be until, you know, 14 or a month that you're really seeing you know, a difference in your animal. But what we need to I also stress is, even just the smallest change. For instance, if a dog was reluctant to walk, you know, around the block and is now wanting to walk 2 blocks, that is a difference, and it's slowly working. So, any questions? What are the questions? Hold on. So the anticipated cost of this for one joint is about $2,700, 25 to 2,700, and for 2 joints, it's about 31 for this treatment. Okay. Yes, the animal is actually anesthetized. So what we usually do is um, we pre-med with fentanyl. We will actually use propofol, and then they are on ISO. And I'll be honest, you're probably looking at between, I would say 20 to 30 minutes that they're actually sedated. And as well as a lot of that is just prepping the joint because everything is done sterilely. So for the discharges, so I don't know if you can see this. What we discuss with the owner is what it looks like for what we recommend. So about 15 minutes at 1 foot from the treated joint. So that is, for instance, like this is considered 1 foot away. And again, it's from the joint to your chest, okay? And then what we tell them, and this is per day, about 4 hours, average 4 hours at 3 feet away. And here is about 3 feet away. So if you're working from home and they like to lay at your feet, we recommend, no more than 4 hours. If they like to lay on the couch with you, you can sit with them for 15 minutes and then either if they're not going to move, then you get up and move and sit at a different area. And then there is absolutely no limitations 3 feet or more. So does this have to be repeated? And if so, how frequently? It doesn't necessarily have to be repeated. It actually is going to be based on the animal and how you feel the animal is doing. Would you say that's correct, John?
Yes, that's kind of why I was sorry I wasn't able to get that video Mykonos to work, because once we treated both those elbows twice, the last treatment was in December 2017, and here we are going on 4 years. So, but that was, that's Mykonos. It's a special dog, I guess.
Yeah. And again, I'm sure you guys all know every animal's different on how they're going to respond.
Correct.
So I believe the research has showed at least a minimum of a year that we've seen improvement. If for some reason the grade 3 is a little bit more towards grade 4, you may only get, 9 months. So any other questions? Okay. Anything else, Jay, that you wanted to add?
Not really. I was really impressed with your practice when I visited it the other week, and thank you for allowing us to present this information. And Jackie can provide my contact information to any veterinarian that wants to get in touch with me about the questions.
Okay. Well, thank you all for joining us. And definitely, if you do have any questions, once this presentation's done, please feel free to email us at Sound. And if it's something that we need to shoot over to Jay, we definitely can. Otherwise, I think we are done. Thank you all.